Thank you very much, and good evening in English, and hopefully in a much more fluent version of my mother tongue. And it is a pleasure to welcome Lisanne Hamilton-Smith. I will ask Lisanne to introduce herself and her very wide background of different involvement in the APN cause to us shortly. And Lisanne's going to talk about her work in the UK and Scotland regarding the APN role. Thank you, Lisanne.
Thank you, and thank you very much for inviting me to this webinar, and I am going to share my presentation just now. Oh, it's disabled. Hold on. Well,
Ich mache Webinar.
Elizabeth, can you stop sharing, or I'll be able to share?
Oh, it's not sharing?
I think it's because you're sharing, so hopefully.
I should have stopped sharing at this point. No, I haven't. Sorry. Here we go.
There we go.
There we go.
There we go. As it's shared. From the beginning. So is that okay? Hopefully everyone can see that.
Yes, okay. That's perfect. Go ahead.
Okay. Thank you. So my name is Lisanne Hamilton-Smith. I'm currently the lead nurse for advanced practice in NHS 24, which is a national health board in Scotland. We are the digital front door for 14 health boards within Scotland and the UK. I'm a senior lecturer for advanced practice in the universities in Highlands and Islands, and also an external examiner for Bolton University and Aberdeen University as well. As you can see, I am Scottish, so there is some delicacies that might be known to the Scottish diet. For example, iron brew, shortbread, fudge and toffee. This is some of the collaborations that I have been working with. So we have Rotterdam students every year in collaboration with Dundee. So that's the top left picture. My team is on the right side, and I do like the Scottish scenery, so I like the boat called the Waverley. And my dog's not here, but I've taken him outside. But today his name is Winston, so he's very much part of everyone's advanced practice journey, especially when we're doing online teaching. However, my interest is obviously having global connections with advanced practice. I've got over 30 years of experience in advanced practice, and I've either been an advanced practitioner or I'm a manager or a researcher, and I have done different things for different places all over the UK as well. So I'd like just to have a wee insight to how I've been able to transform my ANP journey, and it's very much different to everyone's who's on the webinar tonight. My role began as a case manager. I wasn't even an advanced practitioner. We didn't know what to call us. But from there on, we've done very different things. Well, either income generation, creating global communities, producing research globally as well. So hopefully from today, we'll be able to inspire you and maybe get some things produced together going forward. Going forward. Why is this not going forward? Oh my goodness. Right, here we go. So transforming roles within the UK, Barbara Stilwell in the 1980s was from the GP practice and could actually see there was a role for nurses to be able to advance their practice. And if you go back in time, for example, there was the minister was the doctor, or and his wife was maybe the midwife, the witch was the pharmacist. If you go back like in generations time, how all our roles have evolved. And we're either advanced or advancing, but what we are all doing together, and we're all here for the patient, is that we're actually all transforming our roles. Within the UK, it didn't actually really transform until about 2003, with the European Time Directive, and that impacted on the junior doctors' roles. And from that gave the opportunity for nurses to evolve. And also we had legal implications as well. We were able to start prescribing with the Non-Medical Prescribing Act, and also we were recognised with the Nursing Midwifery Council as an advanced practitioner as well. We're not quite regulated, but we're getting there. Not quite like America yet. So in the UK, advanced practice now is not just known as with the nurses, it's actually, we've got social workers, physios, podiatrists, pharmacists, paramedics, a whole range of healthcare professionals now advancing and transforming their roles. And this is fantastic for our patients who have been able to access better healthcare services, especially if they're remote and rural, but also upskilling our healthcare workers so that we can actually take into consideration everything that a patient needs within the system and processes that we work in. In the UK, the minimum that the advanced nurse practitioners recognised is a postgraduate, which is 120 credits at master's level, at level 11. And from that, most trainees will do a 2-year programme to become an ANP. There's 10 higher education institutions that offer the advanced practice programme within Scotland as well. So within that, we have not only our training and our education, also we have competencies. And within Scotland, we have now agreed that we have to have a 2-year portfolio, which is updated annually to demonstrate that we are still competent and confident with our knowledge and skills. So within the UK, just to show you where we kind of sit in the kind of vastness, so the UK has got 16.8 million healthcare workers. It's the biggest employer in the UK. Part of that is about a third is the nurses, and then we've got about 188,000 as doctors, and then we've got our allied healthcare professionals and pharmacists. Now from that, there is a bit of a quandary about how advanced practice is progressing, especially with healthcare professionals, because if you look at us, we're only about 1% of the whole of the UK where we sit as a workforce. So obviously, while we might be small, we can be very mighty as well. But as you can see with MNC, they recently conducted a review of what advanced practice looked like in the UK, and we found that quite a lot of places didn't actually have records. So, for example, Wales and Northern Ireland, and then England, Southern Ireland and Scotland had some registration, but this is not correct, because from that, the Scottish one, I know the 790 was taken in 2017, and from then we know that people have then either called their names differently, different titles, and also they've maybe not recorded themselves on the Scottish workforce system. So it's still a bit of a mystery how many people are out there. However, it doesn't mean to say that we can't still work together to come and work and lead advanced practice, despite all the confusing barriers that are ahead of us. Underpinned by this, we are underpinned by Manley's action research. So advanced practice in the UK is 4 pillars of advanced practice. So your clinical practice is like you're an independent autonomous role, and you do your diagnosis, you do your independent prescribing, referrals, all the things you'd expect from a patient would certainly expect, that one-stop journey. They come to yourself and we can complete their care. Facilitated learning or education is not just about how you receive education, but it's also about how you are being educated. Leadership, most trainee NPs are either band 6 or band 7, which is senior nurses in the UK, and they should be able to lead and also part of that redesign. And obviously everything what we do is other evidence-based practice. However, we do know that the 3 pillars, education, leadership and research, are sometimes known as the forgotten pillars, because people are so focused on upskilling their clinical skills, but they don't realise that the other pillars are just as important, and they will vary as you grow in your role as well. So part of this is that, well, why become an ANP in the first place? Well, it's either be alluring to either the name or the salaries, or just actually trying to make a difference. But like Hecate, we've basically sometimes we can feel as though that we've got different faces and we have to use our different potions and lotions to, with a bit of magic and light, to actually transform our roles. And I'm sure many of you on the webinar have had probably quite like a 90-degree angle of learning, especially when you come from that transition of being in your comfort zone, a role you've been in for years. You put yourself above the parapet, become your advanced practice journey, and all of a sudden you don't know who you are. Nobody knows what you're doing, what you're there for, and there's a lot of misinterpretations and confusion. So therefore you can understand, even when we look at these different perceptions, and you can look to see what you see on my slide just now, is it the duck or the hare? But even when we did surveys with the trainee advanced practice, 42% of the trainees did not even understand their role. So we need to all work together globally and obviously within our own regions to make sure that we understand what we're here for. We're highlighting it, we're singing from the rooftops, because we do make a difference. There's been many different literature out there showing how effective we are, despite all the different whether it's recruitment or competencies or we're unregulated or financial interpretations as well. But from that, we want to make sure that we are really, within ourselves, a force to be reckoned with, that we are here to stay and here to make a difference. Well, there's my three faces, what we look like. Oh, there we go round in circles sometimes when we're trying to make a change. So why are these different perceptions? Well, just as some of the media, especially with our not so nice British Medical Council, have been saying that we should be sought to be abolished. There's no room for us. That why are we not regulated, or being quite condescending by saying the doctor, nurse will see you now how we are increasing our roles. But who is it but what we want to do? However, the MNC 2 years ago started looking at what is an advanced practice in nursery and midwifery. The other allied healthcare professionals will probably see what the MNC will do and then probably align themselves to that. So, and they've come up with kind of 7 principles, key line inquiries, and then they've already produced the principles of advanced practice and what we should be looking at and going forward to be regulated. We know that in America, especially New York, they regulate advanced practice. Maybe it's regulating their title, advanced practice, and not just nurse. But also in America and Australia, they're now, in New Zealand, they're actually making the education required a minimum as a doctorate. So rather than just a postgraduate, 2 years, level 11 masters, they're actually pushing it to be magnet. So there's certainly very much of an evolving landscape from there. So if you look at my career progression, I started, well, I still think I'm young, but in 1990, I started at the Glasgow Royal. And from there, I was a registered nurse and then became a case manager, but then an ANP. And also I remained to be a locum clinician. From there, everything I've done, this is quite a lot I can recognise within this slide, but was trying to just to show you that it doesn't matter what stage I've been in my advanced practice. I've actually tried to, synthesise, audit, and then produce work so that we're always doing that knowledge exchange and learning from each other. Even one of the colleagues I'm on tonight, we did a doctoral poster looking at that very much, that idea. Should advanced practice be at doctoral level, but when is there enough support for us to do our doctorates at the same time? Then I came out being a clinician and I decided to be a lecturer, and then from there I started my PhD. My PhD journey's been quite a rocky road. However, like most studies, life likes to throw us curveballs. It's been like that. Then in 2022, I became a senior nurse, and then I left being a lecturer, went back into clinical practice, but I kept on my role as being a senior lecturer. And then still became still involved in academia, but also probably more being a manager rather than being like the advanced practitioner on the shop floor. And then from there, I've become the lead nurse, I'm still the senior lecturer, and I'm on the third year of doing my PhD. What opportunities I would say a part of my journey is don't say no to an opportunity to anyone. If you've got a chance to have a conversation, move on. You're learning, just understand or attend a webinar just to get that better knowledge exchange of what advanced practice looks like. The world is your oyster, and there's no stopping us in any shape or form. And we're just about to produce a rule of advanced practice book to try and give competencies, because at present there's only 3 countries in the world that have a rule of advanced practice competency framework. So we're developing a book for doing that. Everything we do is fun. Everything we do is learning. It doesn't matter what stage you are. It's always been different for me. Just to give you a kind of scope of what I'm doing this now is that I work for NHS 24, and as you can see, we work in all over Scotland, and the patient can phone in. I can't remember what the number is in Germany, but I think it was like 101 when I was speaking to Rotterdam students. And you've got similar services. A patient, rather than going to the GP or the hospital, they can phone a digital service and access advanced practitioners, mental health nurses, pharmacists, dental nurses, physios, and also a mental health hub as well, to try and keep people away from the hospital setting. We probably roughly do about 35,000 calls a week. It's free for the patient to call. It doesn't matter if they're unwell or well, or mental health or dental. We get everyone, we screen everyone, we assess them, and then we'll signpost them, or we'll complete with self-care, or we'll refer them on to their next their next point of care if required. Different referrals that your patient can go on is either they can go into the ambulance 999, they can go to the A&E department, or we've got flow navigation centres in the UK. Before you go to A&E, you can get to a flow nav or out of hours. Again, it's just trying to reduce the madness that goes into the hospitals where we know there's no capacity. So NHS 24, we're linked to 14 territorial health boards, and it doesn't matter what the patient presents with, we can make sure that they are referred to the appropriate care. However, back to ourselves, because we are advanced practitioners, and what do we do? So we are clinical gatekeepers in NHS 24 NP. So we are able to sustain and demonstrate safe referrals, and we conduct complex clinical assessments either by telephony or video consults. We can do remote prescribing, and from there we can do live referrals into secondary care if required, or to GP practices next day. What we try and do is reduce the emergency department congestion, and we're here all for the same thing. We want to use values-based healthcare and focus on what matters to the patient, and make sure that we're upskilling everyone within the centre, using the 4 pillars of practice, not keeping all our knowledge to ourselves. But while we're improving the patient journey, we can also upskill our colleagues, and we do education sessions and we do research as well. We've got a couple of projects. We've been doing video consultation, learning disabilities, remote prescribing, and education work from. So we're actually on our phase 4 at this now, and we're actually about to put this in. So we tested these projects, and now we're actually at the stage that we're able to now expand and upskill to our colleagues in the digital front door. Obviously, everything we do, we want to think we're leading. We're under my evidence pillar and my QI hat. We make sure whatever we do, we improve the patient access, we enhance the patient's journey by reducing referrals to out of hours. We make sure that we provide robust self-care, and we want to reduce the call handling time on the phone, and also we want to improve the morale within the call handlers and make sure that we're creating a sustainable service for all. Just to show you, there's how we, when you are an NP and you're thinking, how I want to make a difference and how can I do that, then we done everything by staged approach. We're actually at phase 4. But what you can see from this slide, that phase 1, we started with a baseline. We did call reviews. We listened to 600 calls just to find out what the potential source was to improve a patient journey. And then we thought, right, can we do it with video, and we can do prescriptions. I mean, we're doing that. We saved some money. When we did it the first year, we did it for paediatrics, but you can see that the key words was just a small cohort of patients, just because we are adult ANPs, we're not paediatricians, so we wanted to make sure that we were actually safe within our own scope of practice. And we can see that we were still, we did save some money. However, we were quite good at answering the call, and also getting, looking for additional support needs. But then you can see then we actually increased it, and then we increased it to again in phase 2B, that we could see anyone anytime from there. But up to phase 2B, we actually saved the patients and the service 170,000. Now that's a huge saving when we were all trying to save money somehow and somewhere. Because I'm an advanced nurse practitioner, I teach within the rural practice. We understand that there's really difficult with the provision to healthcare from there, whether it's either people don't want to be employed or just the geographical access, and also the cost of living there. What we did was we created a national centre for remote in healthcare and also a programme, and we're on our third cohort this now of remote and rural advanced practice. So we're not just upskilling the kind of urban, but making sure that we're reaching all over. But to make sure that that we're not working in silos, I've created a National Advanced Practice CPD. We've got 800 people on that CPD, and we've been able to deliver monthly sessions on any of these topics and more. And we're now creating a digital platform. So we're not keeping any of our education to ourselves. We're creating a global community of learning. We've worked with the ICN, with the top left is students talking about sustainability. There's a mobile skills unit. I've been working with the fire brigade and different universities and interdisciplinary training as well. And also we created an advanced practice educators forum as well. So we are positive influence, all of us. With our education, we have been able to increase access to free education and make sure that we're all safe for our patients. They love simulation. They really actually fantastically love the whole thing. So, well, I was saying that we're global influencers by working internationally, nationally, and locally. This is just some of the people that we have been working from there. And recent publications this year has come in these versions as well, talking about how remote prescribing can help a patient, 999 calls, and also increasing the education to the patients and the video consults as well. And many of you have probably done an OSCE. We've been writing and validating what OSCE assessments look like. I realise I'm nearly out of time, but Danka, Tablaha, which is in Gaelic, but thank you for listening. I'm more than happy to share my PowerPoint, and I'll stop sharing.
Thank you very much, Lizanne. And it's so exciting to hear what work's happening in Scotland, and such a diversity of different roles as well within APN. I'm sure there'll be lots of questions coming up shortly. For our audience, feel free to write any thoughts or questions that you have in the chat, and we'll get to them at the end of the session. But first, I'd like to invite now Andreas Dirksen to share his screen with us. Andreas currently works, as I mentioned before, at Uni Medicine Frankfurt in an APN role, but Andreas also worked for 12 years in the UK in a number of hospitals, and would like to share some of his comparative experiences between working in the UK in an APN role and then coming back to Germany and working in an APN role here. So, Andreas, the floor is yours. We look forward to your presentation.
Thank you so much. I hope you can see my presentation. And first of all, thank you for inviting me. It's a privilege to be part of this call, following the excellent talk by my colleague Lizanne from Scotland. I'm calling from Frankfurt, not from the beautiful Scotland as she did. Just a brief background. I did work in the UK for a while, and hopefully it inspires and raises some questions at the end. So I'm hoping that's what I'm trying to do, to inspire and share a little bit of the story, what I did as a clinical nurse specialist. A little bit different angle than we had from my colleague. About me, I started 25 years ago in between Cologne and Aachen in Düren. Some may know this town, the city, and got trained in various areas. Beautiful hospital, had a great training, and then moved to the UK in different hospitals. And in 2011, in 2014, had the first time the chance in working as a clinical nurse specialist in syncope on maternity cover, got trained a little bit, and then moved full-time to Hammersmith Hospital, where I worked as a syncope CNS, before moving 21 back to Germany, to Darmstadt. And since 24, I'm now working in Frankfurt as an advanced practice nurse with the focus on heart failure. So a brief journey, and it may look like very straightforward. As a leap, I decided to go to UK. You may wonder why. For me, it felt like at that time it's an adventure, and a different country, language, culture. That's what I've looked at initially. Working with English seemed like a window to an international nursing career, or just something different. And it seemed more structured, what I've seen different from here. Being autonomous, possibly. And to some extent, when I look back, I'm thinking, actually, it was like my English was quite basic. I only had one-way ticket, one suitcase, and I flew across. And the hospital, I'm grateful now, they said yes. So, but then I had to learn step by step to kind of keep moving. That's what I want to look at a little bit more in detail, how it looks like. But when we look at what I did as a clinical nurse specialist, you may have heard from my colleague Lizen, actually, we're looking at Band 7. Band 5, that's where I started as a registered nurse, like in Germany. Then I started working as a senior staff nurse with more experience, or almost like a junior specialist. But to work as a Band 7, that's a clinical nurse specialist, like an A&P, on that's similar to that. That would be Band 7. And then there are the next levels. So, and typically you would expect with a Band 7 to have a master's degree, or in the UK, you could also work towards a master's degree, which I did during this time. I had the chance to start working on the Band 7 level whilst working towards a master's degree in the UK. There, you may have heard the 4 pillars of advanced practice. I've only learned of Hamburg after moving back to Germany. So we had the 4 levels, clinical practice, the education, leadership management, and the research in each role of the CNS. That was kind of something I had to look at every day. And how do I work? What do I do? And for everyone, it looks entirely different. And if we look at in practice, the majority of time, I had just clinical practice was dominating. I was running my TIL test. TIL test is, and if we go a step back, I worked with syncope patients. Syncope means you're a patient who had a brief period of losing conscious and then recovered fully. And we had these patients, we would see why did they actually have it. We would have them referred to. We would only do the following tests if certain, and we would triage them, test them, do a full assessment on our own. In other hospitals, you may have a nurse and a junior doctor running those tests. In our clinic, we only had a CNS running it autonomously. And we would write the report and give recommendation. Often, in most cases, discuss it with our consultant who was supervising or heading the clinic. Then providing education immediately after the test with the patient, having done the assessment, teaching them how to manage their condition, and do it later on remotely as well, over the phone, or later on online as well. Giving talks, and with the study, we started then developing the website stopfainting.com. We started leading services and did other elements as part of our service, the same as developing publications. I was part of the team, which I really enjoyed working with. So these are the reports we started developing. I had to learn a lot to improve my English to be able to do so. In Hamburg, it might be more familiar, but it's the same, very similar to that. Is the most important thing is still as a CNS is direct clinical practice. A lot of CNS, you may know, the majority do is you're working clinically day in, day out. You may not have much time to do so much research. But what we did every day with a patient, we documented the things we've done on Excel spreadsheets, on data files, and reviewed it. We saw patients as well. And at the end, we with another team, I implanted independently event recorder, as we say in Germany, or implantable loop recorders, as we said in the UK. We had our own prescribing guideline for lidocaine, and we did it outside of the cath lab, but I come to it later on. So we followed evidence-based practice, whether prior or during COVID, tried to implement it. It was done. I was involved in doing that, or kind of leading the new COVID SOP, translating evidence what we had and new and local SOPs, ethical decision makings, trying to always fight on what the patient wants, and collaborating as part of the team and discussing that made a big difference, I would say. Leading also whether business case for new equipment, the tilt test or the ILR, making sure everything works. And the coaching the patients, finding new ways of doing that, mentoring the junior nurses, but also the registrars, doctors coming into the team. So if you look at how the team looked like, and it looks very similar. And it started differently initially when I started. It looked like I was working most days running just tilt tests. And it looks very plainly, starting officially from 8 to 4. I would come earlier to make sure the clinic runs. And writing the reports was expected after each test. Some of them were running late. Some of them were quickly done. Doing the admin, triaging new tests, I was part of it. At the end, after my 4 years or 4.5 years of working there, that's how it looked like at the end. The clinic has changed. Initially, it was one day consultant-led clinic in the afternoon on Wednesday afternoon, and the other days 2 tests. But we always had to figure out and make with each other, with my colleague, space to to write data, down to not forget it, to audit whatever we did, and to prepare the teachings. Sometimes you stay a bit longer just to make sure you get your stuff done. So it was a privilege working as part of the team and reflecting, sometimes just having fun as a team, staying a little bit longer, but being part of the team, right? And when you look back, it's hugely like a privilege having done so. So before I go back, that was another exciting thing is if I look at one thing, what happened is from the beginning, we recognized we had a problem. So I described it as from CNS to service builder. Even though I continued working as a clinical nurse specialist, and a lot of you might work in the German-speaking countries, you start a new service. I came into the place and the tilt test was established. That was normal. So if you look at this previous slides, I jumped slightly. Initially, we only had the tilt test. But then we recognized one problem. And before we moved to this one is, we had a long waiting list for these event recorders. And they needed them because we had no answer. And in the cath lab, they would do in between by registrars, consultants, and to see, and they had quite often they would be canceled. The patient satisfaction was low, and they would seem quite expensive for whatever would be done. So we started discussing that, and we developed a team, and there was quite an urgency more and more to do so. Then the idea came out, we need to do it in a different room, so we have consistency. We have our own place. We got trained, we developed a training plan, so it's independent and to be signed off. And the prescribing guideline, because not all of us would be able to prescribe or had the prescribing rights. And as part of it, you may see the team has 2 cardiac physiologists. They were not nurses, one APN and one CNS, one like myself. So we were mixed. So 2 APNs, I should say, actually. So it was a mixed team in general, not only international team, but we were from different kind of, even you had nurses and physiologists. but we had one goal of running the service. And it was quite important for me always making sure we as a team get along, and we could always share the data and work together as in one way. And then we did one audit in 2019. So a few years after it was established, the lead consultant said, hey, how's the service actually going? But we continued doing that. In 2018, initially, the first data, we published something in Europace and after a conference, and the data was good. So then a year later, the lead consultant of the service says, how's it running now after you've been established? And so one of us had to sit down and take some extra time and review the data again. So I did. And you might wonder, why should I take extra time and sit longer? But the beautiful bit was, once I compared the data, I presented it on some slides in front of the doctors and the whole team. And for me, it was incredible just seeing from the old way of doctors believing actually it still works. Suddenly, it wasn't just the patient satisfaction, which was much better. It wasn't just suddenly the new way. There was one established, not everyone trying new things. No, it was a CNS, everyone. We want to make sure the patients are happy. We want to make sure the right patients get the right care. And compared it, we did it in one way of doing that. We evaluated it. We had less costs. We also had less complications, and we increased the cases. Waiting list was down, and patients were happy. A lot of patients were also cancelled, and the main patients were patients who actually didn't wanted it. And that was quite satisfying for us as a team. We enjoyed it. So since I left, they actually expanded the team. They started also removing the devices. So the need has somehow helped them to develop it further. And we could support the patients. Sometimes you take each strength. The physiologists were amazing with the technique. We were better in terms of like putting patients as the center of the service. But together, we reminded each other and we improved the service far better than it could be just on our own. So that was great as a teamwork. And when I look back from one place, and we changed it and we improved the service overall. Something I feel like privileged being part of it. So if I would take something when I look back, and something I've taken even to Frankfurt now, or to Darmstadt initially a little bit, but even more when I started looking at it now, I would say define the role, what you're doing. When I looked at the job like advertised in Frankfurt, I loved it, that there was some description of what I was supposed to do. There was a written role profile in the UK about the CNS. They've described what is Andreas supposed to do. There was a banding, so there was a level, and there was not the full scope of practice, but there was a base. And there was someone I can report to and work with. And I had the same in Frankfurt. I was looking for, who do I work with? Who's my manager, but also who's the consultant I might work with. During the Funded Masters was for me important, finding a way of doing that. But also now is, how do I continue to learn? How do I make sure I can protect the pillars in the UK, the 4 pillars? But in Germany, the Hamburg model, which is a bit more complicated with 7 pillars, most of them, you may not see them every day. You want to lead, but if you look at a survey once given, the majority of CNS internationally and in Europe, they do clinical practice. And the other elements like research is part of the smaller elements of it as well. How it looks like and that could be discussed later on. Make sure your scope is specific, describe, maybe you reflect after a while, write it down and evaluate annually. Sit at the end of the year, maybe see where you've gotten, and you can see that some achievement is done. And if I look back, I started in Düren when there was no APN. There were things are developing in a small hospital, but beautiful hospital. And I was able to help building a service as part of the team. What it took me to get there, one step at a time, I always remain curious and ask why and how we can do it. Not, it's not possible. So I would say is this, I love that phrase from my colleague, the world is your oyster. But it also helped me to have always a good mentor. In Imperial College, I had a colleague who has done a PhD. So, and the consultant had high expectation. So I wanted to learn from them. Had someone always I can ask to work with. Since moving to Germany, I looked for mentors internationally and nationally, who I can work with and to be persistent. That helped me when I have a low and when I have an up to keep going. But when I worked in the UK, working as a CNS, what I loved and what inspired me from the beginning, what I wanted to do as a CNS, and wanted to have the autonomy to keep working, to support patients, to have a voice for patients, as a nurse, but also as a person, as an educator, with my education, with my background, for the patient in the MDT multidisciplinary team, and make an impact. The one thing which makes me smile always when I see how the patient improves, when they feel they're much better. And I would say, try the same thing. Let's keep going and keep trying to do that. Together, it works much better than our own, but it is possible. So thank you for myself, and just a brief look what's coming soon, the book I was involved in, the first German APN book. And then back to Elizabeth.